All right, so I consider all of these full arch cases complex cases, but we also have complex cases with crown and bridge cases. And so I just want to stress the importance of teamwork and talk about the restorative team. So for me, these cases are the prosthodontist or the restorative dentist, the orthodontist, the oral surgeon, or the periodontist. So that's the restorative team when we're not really dealing with implant cases. But it's not a lot different when it comes to the full arch cases, because we still have the oral surgeon, we still have the restorative dentist, we have the lab technician. And I kind of coined a new term that I call intercorporate collaboration, because we have interdisciplinary collaboration. And what I'm trying to make a point is that we have a lot of different companies that have great products. Zest with their locator abutment, Ivoclar with their iVotion denture, and Rose guided smile and full arch service. And when we take these products and these companies and we put them together and we integrate all those together, we can come up with a better product. And it used to be kind of that everybody was very secretive of what their product was, but more and more I see companies partnering together and working together. And really, when you do that, you're going to have better outcomes for your patients. So one of the things that Locator or Zest likes to stress is the simplicity of their case. Now, the last case I showed you was a little more complex because of all the steps and the zirconia doing it in the lab. But I want to show you now a fully digital case. And this is a case that you could use for patients who you're going to convert from, say, a snap-on denture to a digital denture, and see how easy it can be. So this is a patient, Kathleen. She had what she's going to end up with is the bicolored, the two-colored iVotion. The impression techniques is we're going to use a digital scan and a digital workflow, and then we're going to do the pickup directly in the mouth. And so here's Kathleen, how she presented to my office. She had a upper denture and a lower snap-on made not too long ago. And her, you can see when you look how whoever did this didn't really have her in centric relation when they fabricated this denture, because the right side is okay, but the left side has this big severe overjet. And her chief complaint was, I can't chew my food. She would tell me that she can't eat anything. She goes out to eat and her friends are done eating within 10 minutes and she's chewing an hour later. Now, probably a bit of an exaggeration, but you can see that there is a problem here. And when I looked at her closely, I first took her dentures out and I measured her vertical dimension of rest, and then closed my little Boley gauge to the vertical dimension of occlusion, 2 to 3 millimeters less. And so that's what that Boley gauge is set to. And then when I put her dentures back in and had her close, you can see that her vertical dimension of occlusion was greater than her vertical dimension of rest. She stated that she likes her upper denture in terms of the aesthetics, and the plan was to replace the lower denture with a LOCATOR Fixed prosthesis. And so here's the steps that we're going to proceed with to accomplish this task. First, we're going to scan with a trio scanner the upper denture, the lower denture, and we're going to scan the bite. And then we're going to take the lower denture out and we're going to do a 360 scan. So we're going to scan the outside, we're going to tip it over, we're going to scan the inside. So we're scanning the inserts along with the denture itself. Did that rain? Then we're going to place scan bodies, Zest scan bodies, onto those locator abutments, and we're going to do a soft tissue scan And the reason that we do that is not only to give the lab the information of how much blockout we need, but also her tissues may have changed a little bit from the time they made the denture, so the intaglio of the denture is probably not an exact replica of where she is at right now. We're going to send all those scans to the lab and with the instructions to fabricate a locator fixed prosthesis. Now here's the scan bodies that I'm talking about. And they have these undercuts. The purpose of this, once they get this in the digital flow, is so that when the denture comes back, it'll be milled with the undercuts already there, so you don't have to go in and make the undercuts yourself. And just in a pictorial sense, so if this is the mouth, and we have the locator abutments, you place the scan bodies, you scan, do all those scans that I said. It'll give the lab a digital rendering of that ridge with blockout for the processing housings, and then they're going to design the digital denture, process it, and now when you have the denture back, you'll get the denture with flanges. So the flanges are going to support when you're picking up the denture, and then you're going to cut back those flanges after you pick up the processing housings. And this is just a little bit more detail about the digital scan bodies that are still kind of in development, but it's just in order to try to give us an ideal space for the housing, so you don't have to go through all that adjusting and spraying green spray. It's made of PEEK material. It's sterilizable, so it can be reused. So here's what actually happened with the scans. So on the left side there, we did the digital scan. We placed the patient in centric relation so we could capture the bite that she had in centric relation. Upper denture scan, lower denture scan, and then right side bite and left side bite. And you can see here how much of an open bite that she had in that denture, which also contributed to her inability to eat, not being able to bite into sandwiches or bite into a piece of pizza. The middle picture is a picture of the scan bodies, and what really should be done when you do this, and this is not an ideal case because she's had some recession around her tissue, so there's the locators ideally would be a little closer to the tissue, but when you have that recession, you want to block out the undercuts with these little white rings, these little white spacers. And I show that there, but I ran out of the spacers, so I wasn't able to do it on the rest. Because when you scan these, the scanner doesn't pick up those undercuts as well as you'd like it. So you'd like to block out those spaces if there is some. And then this is the 360 scan along with the intaglio. And you just basically turn it over with your hand, take your scanner on the inside, and you basically have an inverse of what the model is going to look like. And they're going to create the model not by pouring an impression into this, but digitally creating a model that's the mirror image of the intaglio of that denture. And so that's going to create an STL file that the lab is going to use throughout the process. And they're going to import it into 3Shape software in order to make the denture. They're going to take that digital scan of the 360 scan and they're going to outline the denture to kind of set the borders of the new denture. And then you can see by making the denture invisible by using your controls, you can see what the virtual model is going to look like that's been made from an inverse of the 360 scan of the denture. And then they can import that 360 scan of the tissues over the top of that model so we have an accurate representation of the tissues. And then the lab is going to create some more ideal blockout just to have a little more space so we don't have to adjust the denture upon delivery. And when you do that, if the denture that she has in her mouth is like a little thin in some areas where the recesses are might show through or might just be paper thin and be a little fragile, they can then take their design and they can add some thickness to those teeth or to the pink portion of the denture in order to thicken up and give it a little bit of extra strength. So then they'll complete the design of the upper denture, make sure that the incisal edge plane is parallel, make sure that all the teeth are in occlusion. They've corrected that overjet that was over here, so now we have a nice occlusion on this denture. And then with iVotion, they position this design in a puck so that the pink part is in the pink and the white part is in the white. And there are some cases where the arches are a little too big, where iVotion doesn't work, where you can't really position it and get the pink in the right spot and the white in the right spot. But in like 85% of the cases, I think they've told me, iVotion would be okay. In other cases, if the iVotion isn't possible, then they can mill the denture in two pieces. They can mill the teeth, mill the pink, and then they glue the two pieces together. And it's still very strong, and it doesn't look like it's two pieces. But this monolithic denture is the stronger of the two. And that's just another view of how they separate the pink from the white. And there's the final denture design. And so after they mill the prosthesis, you can see that we're replicating the flanges. So this denture still has flanges because the flanges are going to be used to support the denture as we pick up the clips. Now, just like any other denture, I'm going to take my pip paste, I'm going to try this in, I'm going to eliminate any pressure spots so that the patient doesn't end up getting any sore spots. We're going to adjust the occlusion to make sure everything's hitting good before we pick up the processing housings. I'm still going to spray the prosthesis with some green spray, try it in. If there are any little interferences, we're going to get rid of that. And Zest has this nice little chairside kit that pretty much has all the burrs. This little burr right here is like the exact size burr to remount these things to make them big enough to accept the housings. And then your undercut burr you have, and some polishing burrs. This burr would be used to drill the little cement release hole if you want to do that. And then your other burrs for finishing and polishing and getting rid of the flanges. Okay, so we've picked up the inserts just like we would do for any removable case. What I like to do is I like to fill the holes, squirt a little bit on the housings in the mouth. I have my assistants making sure that they're retracted, they're perfectly dry. And then I'll seat the denture, have the patient close in the centriculation, guide them so they're not biting off center. And then some patients, what you'll find is they start swallowing, they start moving up, and they're actually moving that denture a little bit while it's setting. And I don't know if you ever did this, but you pick up the housings and then you go in the back and you put the different colored and then you go to pop it in and it's popping out of the patient's mouth. So what I do when I pick them up is I seat it, have them close for about 10 seconds, and then I have them open and I just hold that denture with my fingers so I can keep it perfectly steady instead of trusting them to not move or to not swallow and compress that material while it's setting. So there's, after finishing and polishing and cutting off the flanges. In this case, we use the tan inserts in the back and the front and the blue in between because we have 5 implants in this case. And then we seat the prosthesis. And my purpose with her was because I didn't know for sure if she was reliable in terms of saying that she can't eat. I wanted to test this out to see if this would improve her her chewing ability, and with the thought that, you know, if she liked it, she could keep this for any period of time, or if she really wanted something even better, we could fabricate, you know, use this as a prototype, and then fabricate a monolithic zirconia prosthesis if she wanted something, you know, a little bit better. But in the end, everything fit well. Her speech was improved. Her chewing was excellent. And it's the funny thing about, I've had people ask me, you know, people have these snap-on dentures and they'll have 2 premolars and a molar, and then you go to something that maybe has 2 less teeth. I always find that when we go from removable to fixed, even if there's less teeth, their chewing efficiency is better, for whatever reason. That's what my experience has been. So here's Kathleen in her final prosthesis. I'll say 55,
55,
66,
66, Mississippi, churches, judges, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 55, 55.
Keep your head down and smile big.